Okay, so I am sharing my screen now. We will start. I'll have it presented. Okay, there we go. How's everybody doing? So, welcome to session 6. It's about Introduction to PCORI, methodology and principles. Dr. Rebecca would be mainly presenting this today. I'll just have a brief thought about the prayer, inshallah. So I'll read the prayer today, and would just have one little segment of the prayer expanded so that we can understand what these prayers mean to us. So basically, the prayer is one of our favorite prayers. Bismillahir Rahmanir Rahim. Rabbi shrah li sadri wa yassir li amri wahlul uqdatam min lisani yafqahu qawli. Ameen. Now, I just want to add the explanation or just an intent behind one little segment in there, and which is wahlul uqdatam min lisani. So the meaning of that is basically loosen the knot, or untie the knot, or remove impediments from my tongue. Now, this is exactly what we will be doing and what we would be learning to do through PCORI today. So I just want to add the intent behind this thought or behind this prayer. So what it's saying is, Wahlul uqdata min lisani. Oh my Lord, oh my Allah, loosen the knot or untie the knot from my tongue. Wahlul meaning it's in the sense of dissolving, or it's in the sense of loosening. So when you dissolve a substrate and a solvent into a solution, what happens? The entire solution becomes one, and there is no difference between the substrates or the solvent, right? So this is exactly the word wahlul comes from. It's loosening or untying. Ulama has actually put it in the translated it as untie, because you're untying that knot, that uqda. So uqda is basically a contract, and uqad is actually also used in the marriage contract. So what you are doing here is that you are actually dissolving the contract that you have done with your own language. And that's the intent that we need to have when we say this prayer. And very, very often we do have a contract with our own tongue, with our own language. That's the language barriers. So behind this prayer is the intent to get rid of the linguistic barriers that we have within ourselves and between the two people when we communicate. So when we put that willingness into this prayer, that solidifies itself as intent. So let's make this dua again, or let's make this prayer again, that Rabbi shrah li sadri wa yassir li amri wahlul uqdatam min lisani yafqahu qawli. Inshallah, Ameen. So with that intent that we are going to loosen, or we are going to drop those linguistic barriers in the communications, we will begin the session. And I welcome Dr. Rebecca to actually, or I would ask Dr. Rebecca to move on in taking the lead. But let me here it is. Dr. Rebecca, now the slides are yours.
Thank you so much, Fatima. I really appreciated that. That's really wonderful, and that you've just it's really nice to know that there's a text in the Quran which explains what we're trying to do or helps guide.
Yeah, I was looking at it and I was like, wow, this is what we are doing today.
Absolutely. So I appreciate that very much, because it is hard. I mean, we keep on going back to this. So, we keep going back to the keywords, and sort of we're trying to unlock. We're trying to introduce you to new dialogue, new space, new discussion, but we're also trying to sort of unlock, improve your capacity for a communication in this area as well. And it may be that the skills you learn as part of this course are not, you don't necessarily want to be part of a research engagement project, and that is absolutely absolutely fine. But we want to make sure that the skills that you have got can be transferred into other areas of your working life as well, and your experiences. So yeah, thank you very much. So today we're going to focus a little bit on communication skills, which includes the ability to listen. And I have to say that I think that the ability to listen is a completely underrated skill. And I think when, in sort of society today, very few people can actually listen properly. And then not just about listening, but hearing as well. So what's the difference between hearing and listening? So yeah, so we want to be able to do that to help you use language confidently and appropriately. We also want to help you to document the work. So when you're listening, what are you listening for? How can you listen for things which help you to document your work and help you to communicate with empathy going forwards, and also to be effective and purposeful in the communications that you have with mosque leaders, community members. And also, obviously, all the way through is your ability to improve informal counselling and social support, and also with the long term to sort of reduce health inequities, health disparities, and help improve the mosque population's access to care. So if we can have the next slide. Yes, so we're continuing with some of those other abilities that we've been touching on in the previous slides, and you've done really well to get to the end of this week, and we know you've given you a lot of information to absorb. So now we're going to begin to try and help you basically think, well, what do we do with that all information? How do we start using it? How do we start sort of thinking about our own experience in ways where we can access information, or think about the work we do in ways that will help us to present it to other people? Okay, so if you have the next slide. Okay, so today, so we're talking about the introduction to PCORI methodology, but it's also very much about the principles which are sort of behind PCORI. And I think yesterday's slides gave you a taste of that, trust, transparency, reciprocal relations, honesty. So I want to begin to show you how that works in practice when you're sort of beginning to get involved in asking questions which are collecting answers which help you to sort of form research projects. And there's also the difference between community engagement and advocacy. I think Fatima brought out the idea of advocacy really well yesterday when she was talking about Will County. And that's an example of a county which hasn't got its act together in terms of addressing health disparities, if I understood correctly. It's quite a wealthy county, is that right, Fatima?
There are pockets in there. That's the problem with that county. Yeah.
But they don't have a health equity policy, I was thinking.
That's what seems like it. Yeah. That's really what seems like it.
So that was what Fatima was saying. There's an opportunity there to advocate for the folks who are not getting the access to care. But there's a distribution in that county which is and experiences of access to care which are not equitable. And interestingly, there are counties, for example, in California, where they do have a health equity policy because of COVID. I mean, this has come out of COVID. So the idea is that no county is allowed to reopen unless it meets some health equity targets. And one of those is actually about access to care. So there are examples in other states of where we could advocate for health equity, something like a health equity policy, in order to reduce those barriers and those distinctions. So we're going to talk a little bit today to show how I'm going to talk a little bit about the methodology, how you can, when and where you might want to reach out to a researcher for some background information, or reach out to Fatima for some more information about the Worry-Free organisation and how it can help you. And as we're also talking about communication skills in terms of, so to make sure that you are informed so that you can ask the right questions and also communicate effectively with a whole range of different people. So, and then on Monday, you will get the Dr. Bidell will talk more about the mosque context and its stakeholders. So you'll begin to be able to think a lot more about the mosque context. This little diagram here, Be a Neighbourhood Hero, I'm going to talk a bit more about this when we come to do a little bit more in-depth asset mapping structuring. This is actually look to join mutual aid groups in your area. And these are groups who are getting together to, for example, deliver food banks and they're sharing assets, they're sharing resources. And this is a very good guide to how you can identify those resources and the assets that you need to progress your agendas or your organisation's agendas, and it helps you it gives you tools to do that. But we'll come back to that when today we're just we're beginning to think about people as assets and organisations as assets. Okay, so have the next slide. Before we go further, I would like to do an icebreaker. So I'd like you all to share a highlight of this week, either at work or personally. And I'd like to share my highlight first, is that, and I'm sorry, I'm getting to know you all, so I'm not quite sure if I'm remembering the right person who said somebody shared, I think it was yesterday, somebody shared the Snappo. Which I thought was wonderful. The idea that people are applying for their SNAP benefits. You're getting training volunteers to help people complete those forms for the SNAP benefits, and it's a whole sort of it's in mix at a food bank. So it's joining the dots between making sure people can get access to the food, and also that they know how to get the benefits. They know how to be able to sort of pay for it. And I wanted to share something that a colleague of mine shared a few months ago, actually, and I wasn't sure if it was relevant to people, but you can actually use your SNAP benefits to buy groceries online as well. And because I work with older adults, things like this are very useful, because if somebody can't leave the house and go to a food bank, it's useful to know that there are things like this. So I wanted to share that. So that was a highlight. So thank you. I can't remember who it was that shared the Snappo.
It was Andy, actually.
It was Andy.
Okay. This is amazing that Amazon is accepting the SNAP card, basically. So that's what it means, that if you are buying these groceries on Amazon, use your SNAP benefits to buy groceries, which means Amazon is linked with the Department of Health and Human Services backend, where because for the link card, that's the Illinois food stamp name of the card, link card. So which means that they are actually have a way to bill them, and they get paid from them. That's how that card works. Okay. So this is amazing that Amazon has done. And in fact, what I'm thinking that as a community-based organization or even faith-based organizations, what they can do is have volunteers where they can help the elderly have a little, kiosk maybe, or have a computer available, and they can help the elderly buy groceries online, or help them pick out and place the order, and the groceries will get home.
That's right. That's right.
So this is great service for somebody who is coming to the mosque, and actually, I'm just thinking out loud here. Thank you.
No, but that's good. That's exactly what we're doing. Yeah, we're thinking out loud.
Also, a cool benefit with the SNAP card that they don't say is that if you do have a link card here in Illinois, it's only $5 a month for Amazon Prime, and then it gives you access to $5 yearly memberships for Divvy Bike, and free access to pre-COVID all museums in the Chicago area, which is really nice.
Beautiful. Yeah, we got to know how to promote. That's a big asset.
Yes. Thank you, Andy. Thank you. Okay, so now I just want a few more people to share their icebreaker. I know we've got a lot to get through, but it would be like, could somebody else share highlight of the week, personal or professional?
I can show you all mine. We started fostering a puppy, or he's not a puppy, he's 2. And he's a big needy baby, but he officially got approved for adoption, and he will be adopted next week when we take him in to get adopted. So he came all the way from Alabama.
Oh my goodness. Oh, wow. What's his name?
Draco.
Okay. So, welcome, Draco. Okay, thank you, Andy. Anybody else like to share a sort of highlight of this week, professional or personal?
Well, I just got done with work, but my highlight of this week was I got to finish 4 books that I was trying to finish for months, but
Wow.
I was thankfully able to finish them this week. I just powered through them all like in the past 3-4 days, and they were like audiobooks
Wow.
and like written books, so I'm really proud of myself for that. So that was my highlight of this week.
Oh, cool. That's very good. Well done. Is that Asna? Yeah. Okay, one more. Can we share one more?
My highlight of the week is actually today. After this, I'm going to a barbecue.
Way!
That's nice. Beautiful weather.
Cool. Oh, enjoy. That sounds really nice. Excellent. Oh, thank you guys. Okay, so that's really good. All right, so let's do a quick knowledge check. So how many, and again, use the chat function. So we're just trying to sort of make sure that you can, I know it's a lot to take in, so we're just wanting to sort of begin to reflect back on what we've done. So how many years do you have to have worked in these states to be eligible for Medicare and Medicaid? Is it A5, B10, or C15? Mm-hmm. Yeah, cool. That's right. It's 10. It's 10. Well done. B. So which of the following access issues have been considered by PCORI research teams to improve access to care for Medicare and Medicaid consumers? Now, remember I showed you some projects yesterday. So is it A, transitional care for stroke patients, B, access to mental health services, or C, coverage for children with autism? Guys, you're wonderful. That is right. It is A. It is A. It is transitional care for stroke patients. And yeah, I hope you remember what transitional care is. It's not managed care. Transitional care is when you're moving from a hospital to another care setting. So thank you so much. Good. Oh, well done. Oh, that's wonderful. Okay, so next slide. Okay, so today we're going to speak in the same language. We're continuing, to explore these words that we all need some shared understanding of, but also you should define them yourselves. What do they mean for you? Because one of the hardest things is just to sort of say is talk concepts and talk at concept level. I mean, these words have to be meaningful to you for you to be able to explain them to other people. It never works if you're trying to explain things that are not meaningful to you or you don't understand fully. So health equity, which is a really big buzzword at the moment, is a really big area, and you're probably hearing it all over the place. Then we're going to talk about a little bit more about health behaviours and people and organisational assets, and the PCORI research engagement rubric and principles. And really these principles are respect, transparency and honesty. So how do we go about making sure that our behaviours as community health workers, researchers, sort of worry-free organisation members who might potentially be a research team working together, how do we ensure that our conduct is respectful, transparent and honest as well? So does anyone want to have a go at defining health equity before I give you an explanation? Does anyone want to sort of have a go at saying what health equity is, or a simple definition?
I can give it a try. Isn't it like when everyone has that equal opportunity access for care, but some might need it more, some might need it less, but it's still equal in that sense?
Yes, absolutely. It's not equality, but it's perhaps more important to the second half of what you said, that it's about having equal access. Yes, that's right. So yeah, if we go to the next slide, I can show you the, thank you, that's lovely, that's really nice. So what is health equity? So equity is the absence of avoidable, unfair or remedial differences amongst groups of people, whether those groups are defined socially, economically, demographically or geographically, or by means of other stratifications. And it means the route to achieving equity means that everyone has a fair and just opportunity to be healthier. Yeah. So, and you can see this little diagram here is often used. This is the Institute of Social Change. People have issues with these diagrams, but I think it does. I think it does show you the difference between equality and equity. So equity is enabling the smallest person to see over the fence, whereas equality would just be giving everybody the same boxes, the same sort of size of boxes. So yes, it's helping. Health equity means that everyone has a fair and just opportunity to be healthier. Yeah, fantastic. Okay, so that's great. So we have next slide. So what are the assets we can access to impact health equity? So we've been talking a lot about access to care, and we've been talking about employment, the importance of, how your income, your all these factors, all of these social and economic factors impact whether or not you can have access to care, but also what your needs will be as well. So today, if we go to the next slide, we're going to talk about tools which facilitate equitable behaviour and communications, because we have to help everybody sort of to promote health equity. We have to understand how to ask people what they need as well, in terms of to sort of find out the things which can reduce disparities and improve health equity. Okay, so for the next slide. So we're moving more to the grassroots. So asset mapping today is very much focused on people and organisations. And Andy is going to talk a little bit about her sort of relevant experience to our group, to our sort of project. But I also wanted to share these templates, these bio-sketch templates. This is an example of myself sort of trying to summarise my relevant experience for a project called Bureau of Sages, which was with a group of older adults. And I was part of a research team which had older adults, caregivers, home care aides in that one. And then this is Beverly Rogers, who is a informal caregiver and who was on a board. It was a home care aid project, and she had used home care agencies and had a lot of valuable information about the experience of doing that. So we both sat down and we both wrote down, what we brought to what our perspectives on engagement is, why we want to do it, research engagement, our roles, and our relevant experience. And I would really encourage you to do a similar thing, create a template, because this enables you, when you're going to see a mosque leader or another person, another organisation, it enables you to explain very simply and clearly who you are, what you do, and why you're interested in, why you think research is, your perspective on research engagement. So I'm very happy to share some blank templates, but and you just need a sheet. I know you've got your CVs and you've got your official things, but it does help very much to sometimes do this, and it reminds you then what's important, what you value, what skills you value and think you're bringing to the table. Okay, so if you have the next slide. Okay, so Andy is going to she's going to talk about her story, her experience, and as you listen to Andy, I would really like you to really listen hard, and I'd like you to make a note of all the organisational assets that she mentions and she draws on, and this is so that we can sort of begin to fill in the organisational assets part of an asset map. So we really want you to think about what an organisation, the organisational assets, and we can share what those are, and just sort of see what we hear at the end of it. Okay, so Andy, it's all yours.
Back on. So, sorry, can everyone hear me?
Yes.
Cool.
Yeah.
I thought it was going to happen much later, but basically I just kind of want to talk about what I do here in the Chicago area outside of the Greater Chicago Food Depository. I'm part of a volunteer organization called Chicago Volunteer Doulas, and what they do is provide doulas at no cost to families who qualify in our qualifying list. We have a long list of things that qualify you for a free doula, and if you say yes to any of those or self-identify as any of those areas of need, you'll get assigned a doula. And how the process works is just any point in pregnancy, a mom or birthing person can request a doula through our page, and at 36 weeks, sometimes even earlier, especially if they're expecting multiples, you'll get assigned a doula, and we're kind of like case managers in the sense of everything up until 2 weeks postpartum and through the birth. We're providing resources, support, spiritual care, emotional care, just kind of giving, trying to think more as just like a central point of resource for the birthing folks and whatever they could possibly need. One of the things another highlight, I did get to attend a birth, so I missed the first 2 days of Monday and Tuesday, so it was really interesting to like apply some of the stuff that I've heard and like now see it in a new perspective because we conduct our own research during the births. Something I've noticed and like how Fatima and I got talking about this was I've had a situation where I get to see, unfortunately, firsthand experience of like the lack of resources and the lack of care for certain ethnicities and races while they're in the birthing experience, and especially in the hospital, and COVID has like exemplified it. I've had nurses write off patients because of their situational, and it's just they only know the person when they come into the hospital through the point of their birth and when they leave the hospital, and they don't really care to know any extra information, but they get judged so hard on that to the point where I've had a mom almost catch her own baby in a hospital, and like people kept pushing off her pain. She was just like, I feel uncomfortable, something's wrong, something's not right. And the nurses are like, it's fine, you're in labor, that's what you need to deal with, that's just what labor is. To the point where she's just like, can you just check for me? And like I check, baby's head's already out, and she's like she's birthed baby's head all the way to shoulders, and I just asked her, okay, don't worry, we'll stay calm. Just hold baby's head. You can put your hands down there and we'll keep them inside. And then I'll go get a nurse. And it took about 5 minutes, and she held baby in for about like 3 to 5 minutes on her own until a nurse actually believed me, because they weren't answering our calls on the button. I had to go to a nurse's station down the hall to ask for them, and no one believed me. And then the following morning, when a fellow Black nurse came and I told her that story, she told me, oh, that wasn't reported. The nurses on the overnight shift did not say that in her case notes and what happened in the daily meeting, in the daily debriefing for the day shift nurses. So I found that really interesting. And then it even exemplified more for this particular mother where, where after her birth, they took baby to nursery so mom could eat. And like, we always kind of highly say like, hey, try to keep baby around. But the nurses were very adamant. Oh, she had like, we're taking baby. And just because of her financial and like circumstances of her coming into the hospital, they wanted to take baby. And in that situation, I didn't know enough of what was happening in the hospital with like social workers, and this particular hospital has conflict with doulas, so I always have to be on my best behavior when I'm there, and I can't ask too many questions because sometimes, even though doulas do not give out any medical advice, we advocate for the mothers and birthing folks, and we help uplift their voices. And sometimes nurses do not like that, I've learned. But the worst case scenario with this client, unfortunately, she got written off again, where she was kind of coming in and out of consciousness, and she was just tired. And the nurses were like, you're hungry, you haven't eaten in almost 25 hours, just eat your food and you'll be fine. And then they left. And within 5 minutes of me kind of just noticing her symptoms and asking how she's feeling, and she's like, I'm not feeling well. She passed out completely and was hemorrhaging all the way to the end of the bed, to the point where I pressed a button, no one came again. And I had to be like, okay, it's life and death situation now. I run to a front desk and like, hey, no one's paying attention to us. Can I get someone to help? She's hemorrhaging. And I just have noticed that more frequently in some of the West Side hospitals, where especially Black mothers who already have a high mortality rate, are getting pushed aside and not being, they're like, you're fine, this is what it's normal. But unfortunately, I've noticed that most people don't know what a normal birth looks like because no birth is similar. Every birth is different, every body is different, and we don't talk about it too openly. And everyone's just kind of like, oh, it's fine, you'll do this. So that was the key story I had told Fatima. And it started off just because I had another really long, non-traumatic labor this week where it was like 36 hours of nurses just saying like, you're fine, you're doing great. Sorry, I have someone picking up something. You're fine. So yeah, it was just like nurses giving maximum amount of medication, maximum amount of everything against mother's wishes. And they're just like, it still ended up in a C-section, but unfortunately they were more friendly on having her choose her path, which I feel like it helped with having a doula and an advocate there to like help her be confident in her choices. So hopefully that kind of covered it. Sorry he's barking. I'm going to put it on mute. And if you have questions, let me know.
I'm sorry, I was on mute. So thank you so much, Andy. That's a really, really great example. And actually, what I was noting as you were talking is that it's not just the organizational asset, it's what they're not doing, isn't it, as well? It's because you've got access to the hospital and all of what's going on in there, but there's a lot that's not happening there, which would be helpful to you. So I think that is really great. So what's the name of your organization? Sorry, I didn't catch that.
It's called Chicago Volunteer Doulas.
Chicago Volunteer Doulas, yeah. Mm-hmm.
So like our goal is to get more Black, Indigenous, people of color, more language to like cross the language barrier. Right now we only have maybe 3 Spanish speakers, maybe occasionally, if they're not on maternity leave, 1 Arabic speaker, but we serve about 10 hospitals. And it's like, one thing we're trying to do is the education of people that they can ask a doula, and hospitals won't. We have an on-call system at those 10 hospitals. If a mom's alone or wants someone to advocate for her, they can tell their nurses like, hey, I want a doula, and we get called in. But a lot of people don't know that. And we're trying to figure out how to close that barrier of like educating people, because the hospitals won't do it unless they have a midwife, is what we notice. But right. OBs, OBGYNs, and the nurses don't know about it. And OBGYNs sometimes are just like, you're fine, you have the nurses, that's what the nurses do. But the nurses, other than they get a caseload of like 2 to 3 people sometimes, and they can't give you individualized care or support.
Yeah, no, I understand. Yeah, okay, so that's really interesting. So would any members, any of the group, like to sort of share about what they've heard? So obviously we've got the wonderful sort of Chicago, the Chicago Volunteer Doulas, and that is an organisation, and then we've got the hospital, these 10 hospitals, and those are each organisations with their own operational structures, but there isn't necessarily understanding of between the 2 types of organisations of the values of the doula. So are there any other organisational assets that you heard in Andy's talk that you'd like to sort of highlight for us?
I heard the word midwife.
Yeah, okay. And that's a good question, because are midwives attached to the hospital, or are they attached to the doctor, or are they attached to, how do the midwife fit into the picture?
I don't know. I was wondering about that too.
Mm-hmm. Mm-hmm. Sorry, was there a question?
Yes. So Andy, it's probably for you. So how does the midwife fit into the picture? Who employs the midwives?
Goes to insurance wise. So that's why I'm like learning about the insurance, and I really appreciate it.
Yeah.
But it's just whoever some insurances don't cover midwives because they're not as expertised as an OBGYN. So it's based on client preference and if the insurance will cover it.
Okay, thank you. Yeah. So as you're talking, I'm thinking there needs to be education for professionals within the hospital, and actually you're making me think that your role is really interesting, because there are I've noticed in American hospitals there aren't often social workers. There aren't many social workers, but they do tend to be hospital chaplains, and they tend to be they are supposed to be non-denominational. They're supposed to be able to help everybody, and they also take on a similar advocacy role within a hospital. So often people and their families will share what the patient needs, and they might be an outlet to help sort of just pass that on. So yeah, I'm thinking how we can trying to join these gaps. But anyone else on the call, would you like to sort of think about any solutions that you have in mind, or other organizations that you think might be able to help?
Hi. So I'm just wondering, like, is there like an institutionalized, like the hospital has a policy that is not working with it together? Is it just people's attitudes? Like, what's exactly the problem? Because it seems like an amazing program. I don't understand, as like someone who's worked in hospitals as a medical professional, I understand that in the day-to-day, like, things that we do, we don't have enough manpower to do everything ourselves, and seems like an excellent resource. So from your experience, can you share maybe like what you think the barrier kind of is between the hospital administration? Is it legal? Is it I don't understand what.
Yeah, so I'm still a baby in all of this. I've only done 10 births, but from my understanding, birth in America is a business. And that, like, kind of from my understanding, it ties into insurance, which is wild to think about sometimes. If you look, it's like so silly, but it's something so minuscule. Look at the most popular birth dates. People born in America in like the last 10 years on major holidays is a lot less now because scheduled inductions are a thing. I've had a client who's due 4th of July weekend, and they try to induce her the 3rd or the 2nd because they're like, well, your doctor might be on vacation. We want to make sure your doctor can attend your birth. So we're going to induce you 2 days early. So that's kind of a thing where it's just kind of like, to me, it seems like a money game. And then legality, we've taken away the opportunity for freestanding birthing centers ran by midwives who are supervised by OBGYNs, and they report to someone, or the opportunity to birth at home as well. It's coming back in Illinois, but it's still very not common at all here.
Okay, that makes sense. So I understand the business aspect of everything, so I'm thinking, is there any way to work together with some of these hospitals to at least, because like the purpose of this organization is to provide care to people who cannot participate in this business model. So is there some way that you can, like, I'm thinking, like, talk to these hospitals and come up with like a plan that only specific people qualify, so that it doesn't interfere with whatever business capitalist agenda that they have?
Honestly, that's a really good point, and I would love to know how to introduce ourselves into like the hospital administration and like implement policies. But sometimes the hospital experience to me is like a little bit toxic, where like the nurses really dislike the doctors, and there's all this like there's just tension, and it feels like high school all over again, no matter what.
Yeah, no, I can relate. No, so I think so definitely we need someone who's studied hospital administration to get on board. We need to find someone like that, probably. And then I'm sure there are other organizations. We'll have to do some research, I think, to look around for it, but there must be some like legally orientated like organizations who would have, I think, experience coming up with protocols like these. I can I will look around too, because I think there are some people I know who do work in hospital administration. Other than that, I think emailing hospital like committees and asking them about their perception, perhaps, on some of these ideas, at least. Because then they themselves might tell you what they need from you.
I would, yes, and I would encourage, maybe we can get, I'm sure there are OBGYN doctors who would appreciate what you do very much. And so it's getting people perhaps to share experiences and listen and sort of, you know, get together at a table just for a sort of brainstorm. Maybe that might help as well. I think, you know, what you've just shared is just fantastic. And you put your finger on a whole series of things which shouldn't be too difficult to address. Yeah, okay, so I will also think about that. And I know, for example, I know there's a doctor at Northwestern Memorial who she wanted birthing pools. She wanted sort of many more options of birthing pools, which and she advocated for that. So I'll reach out to her and see whether or not there would be just to see if we can make some connections.
I think, yeah, that's an excellent point. I think there's definitely OBGYN doctors out there who are already participating in research to like lower adverse outcomes, and I think they would also be really interested. So if we can like look online and look in these departments and see if anyone's already participated in research like that, you could probably reach out to them too and email them.
Mm-hmm. 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 Okay. So definitely come back to that, Andy. We won't forget. So, you know, and it'll probably be next week sometime, but we'll definitely follow that up. So thank you so much. I really appreciate that. That's wonderful.
Thank you.
Thank you, Andy.
I hope you're beginning to understand how valuable you are as assets. Everybody at the table here is really valuable, and it's really good to listen to each other and hear each other's stories and ask questions. So I would like this to happen every time we get together. So would somebody else like to volunteer to follow Andy and do a sort of similar sort of story about their experiences of work, about their organization, their sort of the assets that they have and they provide for people, and maybe some of the barriers like Andy was saying as well. Do we have a volunteer to talk on Tuesday with me? I wouldn't want to interfere with Dr. Padella's schedule, but Tuesday would be the next one.
Any volunteers, guys, who would want to talk about their story on Tuesday?
I don't know, because I haven't been able to, because of COVID, I haven't been able to work with the UPNA clinic that's there in Westmont, Illinois. But maybe I could discuss with them, because there's some things that we've seen too. But I just have lost a little bit of connection. I could ask them, and maybe if like anyone else wants to volunteer too, I'm sure there's gonna be other times that we want people to share. So we'll email you if we can do it or not.
Perfect. Thank you so much. So yeah, okay, that sounds really good. And I realize COVID is restricting what we can do, but I think actually that's any if you could reach back out and sort of perhaps ask them about how COVID is impacting the organization as well, that's all useful information to share as well, I think. So that would be great.
Right.
Yeah, thank you. Awesome. Okay, so we've got Joaria next week, on Tuesday. Okay, so if we can have the next slide. Okay, so what I wanted to do is give you a little idea of, and I would rather have chosen food actually, given that we've been talking about we talked a little bit about food banks, and I'm understanding that a number of you are involved in as volunteers or in providing food. But actually, physical activity and mobility is also you remember the diagram where we've got diet and exercise. Those two things are going together. So these are also very valuable So we're moving now to talk about some health.
30%?
Mm-hmm.
The health behaviors contributing 30%?
Yeah, that's right.
That's what you're referring to? Okay.
That's right. So we're now beginning. So we've had a great discussion there about access to care and a particular example. So now we're thinking about, I want to move you through in terms of how do we actually ask about things like diet and exercise? How do we find out about physical activity and mobility preferences? Now, I'm going to give you an example of older adults because that's my background. But I can, if other people just let us know what research you need, because I'll explain how the research can help you and you can draw on it. And please use Fatima and I's resources. So Fatima is a resource to tell you all about the worry-free organisation and insurance and how to use that. Please feel free to use me as a researcher and say, actually, I want to know, I've got this in my mind and I want to know a bit more data. I want to know a bit more about this. So I'm going to give you an example of the physical activity, how to find out about physical activity and mobility preferences. Okay, so next slide. So every day we all do. At the first, I just want to say we all do research every day. All of us do research. When you visit a local gym to see the facilities and speak to the staff, particularly now, you're basically saying, does this gym practice social distancing? Well, do I feel safe? What do they offer? And then, of course, when you phone two shops to find out whether they have an item in stock and you're comparing prices, you're doing basic research. And you complete a questionnaire, as you may have done with the census, or every time you go to the hospital, often you're asked to do some sort of pre-survey. I got one recently, which was clearly got it because I was over 50, and so it was asking about all these. It didn't paint a great picture of aging, I have to tell you, because it was asking me what was going wrong with my body, basically. So yeah, but you have to fill in those. And my mum hates survey questions because she says they never ask her the questions she likes. So she always writes a little essay next to the survey questions just to explain why it's the wrong question. I love my mum. She's very she's very good. She's not going to take any nonsense. But, because I think she was asked whether or not she ate biscuits, and she was very indignant about that. She said she didn't eat biscuits, she had shortbread. Which of course is a biscuit. And it's about sugar intake, that one. But and then of course you may have been asked to lead a voluntary group, and I've given you an example here is that you may have been asked to, for example, lead a mosque community exercise group for older adults. Okay, so these are all examples of everyday research, not official sort of IRB, which means Institutional Research Board, where you have to go through a whole series of sign-offs. These are not clinical research. This is everyday research. So I want you to imagine your mosque is in a community area with fewer recreational and fitness facilities than the national average. Imagine you have an interest in leading a new group at your mosque for older adults to improve everyone's physical activity and mobility. And you're a member of a research team tasked with understanding older mosque community members' preferences for physical activity and mobility. Okay, so just imagine this scenario. So the first thing is, and this is where we bring in Pecori's principles as well. Remember, the transparency, trust, honesty, reciprocal relations. Well, to be transparent, you need to be informed. So you need to understand what you're doing, and you need to understand why you're asking questions. And if this was part of a research team, you'd need to be in touch with your research team regularly and you need to discuss with them the questions that you are going to ask. So the golden rule 1 is being informed. Okay, so next slide. And how can researchers help you? So the researcher perspective, they can provide you with national trends. They can provide you with information about Chicago. So, for example, you can see here that there's the number of residents right at the bottom, number of Chicago residents between 65 and 84 is going to double by 2040. So it's likely that the populations of your mosques is going to get older. And there's going to be more older old people as well. It's very annoying. Lots of the statistics just talk about people over 65 or under 65. But there's a big difference between being 65, 75, and 85 in terms of your experience. So that's how researchers can help. And don't feel scared to reach out to them and ask. One thing researchers are actually really good at is literature reviews. They know where to get your data, and they know how they can. They're willing to share that, and you can get that from project summaries as well. Okay, so next slide. Okay, so just to give you a very, a visual. So people aged 85 and over are the fastest growing section of the American population. By 2030, the percentage of Illinois residents over 65 will increase from 18 to 22. And the population of Chicago residents over 65 is about, we round up, so that's 12%. Now, you'd have thought that there was a growing professional training of geriatric specialists, but there isn't. So that is something that I can see happening over the horizon, is there's going to be a shortage of doctors who've got specialisms in what the American system calls geriatric conditions. I don't like the word geriatric because back in Europe that means something different actually. But here, that's doctors. Geriatric doctors are ones who support older adults. The other interesting thing is this. When you look at the numbers, sorry, can I scroll down? I can't see the bottom of the slide. Sorry. There we go. Yeah. So what's very interesting here is that you can also see, I think it's about, in Chicago, the population of Chicago residents is 11.8%, but it's almost 50% white, 50% black. So it's actually that is, and yet the services, as you know, are not spread equally across the city. And as also, you know, the life expectancy is not equal across the city. So there's a big equity issue here. Okay, so if we go to the next slide. So the characteristics, so 33% are living alone, 22% speak English less than very well, and more than a third have a disability. And there's the issue of dementia, which we won't talk about today. But there is evidence that African Americans are 2 to 3 times more likely to have dementia than non-Hispanic whites, and Latinx are 1 to 5 times more likely to have dementia compared to non-Hispanic whites. But there's also issues of misdiagnosis. And so it's also about access to the right, access to doctors who know what they're talking about, which goes back to the problem of there not being enough doctors in this area. Okay, so if we keep going. Aging in Chicago. So just summarize challenges and strengths. So we've got the same. So we have the next slide. We have this one. So we have healthcare disparities. So here again, this is what a researcher can help you do. They can help you plot where things are happening. And we talked about that slide before. And we've got inequities in life expectancy, which are not just about they're not just about place, they're also about race and ethnicity. And the gap is widening due to chronic disease, mental health, substance use, and violent injury. These are some of the other reasons for those gaps on that map. Okay, next slide. So again, what a researcher can do is they can provide you with, where people are. So this is a map of the older population in Chicago. So you can see the light blue is where it's less than 250. 250. The darker ones are where you've got sort of a higher population of older adults. And this is by the census tract and community areas. So think where your mosques are, and then think about whether or not your mosque is in a place where there's a lot of older adults. So again, that's what a researcher could help you do. They could help you really think about your environment and who is living, who's around you, and whether or not you are actually going to. I mean, it wouldn't be sensible to necessarily have a mosque doing a physical exercise regime or services in an area which was a very predominantly for young people. So it might not be a good help. These maps help you decide where your business can thrive, where your services or your assets will thrive. Okay, but the next map, if we just show the next map will also show you basically where there are. This is an interesting map because this shows you where there are gaps in recreation and fitness facilities. So this shows you all the red areas are where people don't have. They have a yes. They no, hang on, is that right? I've got the wrong way. I got the wrong way.
Recreation facilities and fitness. Yeah.
Yes, that's right. So yes, so they must. So it's all on the edge of the city where you haven't got as good recreation and fitness as further in, which is interesting. So there's a sort of donut effect with Chicago. So again, think about where your mosques are, and are they in areas of, there's a lot of options for recreation and fitness, or not. This is actually a map about active transportation to get to work, but it's a useful map in order to think about recreation and fitness facilities as well. Okay, so if we go to the next slide. And the other piece of information that a researcher could share with you is this is from a survey we did, Age Friendliness of the City of Chicago. And this tells us about distance to services. Now, with older adults, normally people think about, if you've got access to facilities or services within a 3 to 5 mile radius, that's good. Older adults can't go beyond, it's less than a mile is whether or not there's, it's accessible often. And here you can see that it's about 55% of older adults have a pharmacy service with less than a mile away. About same amount for healthy foods. But look at this, you've got health clinics, dentists and doctors are more than a mile away. So that would tell you that those older adults are actually quite dependent on somebody to take them to those for health clinic, dentist and doctor. Okay, so next slide. So then the golden rule too is having respect. So listen, as we're doing, we're doing a lot of that today, which is great. Imagine yourself in another person's shoes. And that's very hard when you're faced with somebody who's had 85 years of experience. It's difficult, and you're 20. Yeah, it's extremely difficult. It's not easy at all. But communicating clearly, acknowledging that other people have different ways of seeing things is half the battle. Is really half the battle, and listening. Okay, so let's go through having respect. So, and then also being reliable, honest, and trustworthy. So, yes. So, if you're going into a situation, if you're part of a research team, you see, I could imagine Andy being part of a research team, with a researcher and also other community organisations and women with postpartum depression, and also women to experiencing their having childbirth in a hospital. Maybe Dr. Rasool as well there. That would be a great research team, and they would all be coming together. So if you are in that position where you're at the table, you're not just listening to the people in the community, you're also listening to all the other experts around the table. But if you go to the next slide, what's really important is that you trust each other, that everybody's reliable, honest, and trustworthy, and are on the same page. So if you follow any protocol developed by the research team about the questions you're going to ask and how you're going to ask them, and you protect and promote client rights in accordance with any conditions of participation practiced by any member of the research team. So as an organization, you might have sort of, ways to do things. The hospital obviously will have ways to do things. And so there's all these conditions which you will need to be aware of in terms of the rules, in terms of what you can ask people and what you can't. So, and that is a key part of being reliable, honest, and trustworthy. And we'll talk a little bit more about researcher behaviour when I talk to you about the processes that researchers have to go through in order to show that their projects are not going to harm people. Okay, so if you go to the next slide. All right, so the first thing is you need to understand, you need to be knowledgeable, you need to sort of, understand what you're doing. So with this one, you would need somebody to help you understand examples of what older adults can do in terms of physical exercise. You're not going to recommend to an older adult 85 that they go for a jog, or that, you know, they're doing strength. So, but the sorts of things an older adult can do are often home-based, which is good, but they could be stretching, seated-based stretching exercises, lifting, but not weights, bending, walking, and balancing. So these, you have to know your area. You have to know what you're asking. Not in depth, but you do have to know what type of examples exercises your mosque community, your older adults in your mosque community might be able to do. Okay, so if you go to the next one. And some of the barriers they will share, many of the just to give you a little background, you need to understand some of the barriers and not to be surprised by them. So many people aren't interested in doing physical exercise. I've had older adults say to me, I'm 85, I've done it like this since forever, and I'm not changing. I said, I'm just not doing it. And also there are all these fads, all these diet fads and these physical exercise fads. There's going to be a new one in another 5 years. Why would I learn a new one? So there's a lack of interest. More importantly, there's a fear of injury and a fear of falling. Falls are one of the biggest reasons for hospitalizations. And interestingly, when I had to go to hospital with my fingers, I was asking them and whether or not falls and injuries had gone up. And this was in the emergency room. And they said, yes, that they had an increased number of falls, and it's pavements, people tripping over pavements, and all ages as well. So kids have been falling over as well. So, but the fear of injury and falling is a really, older adults fear falling a lot, and so that's so setting up an activity would have to avoid falling. You don't want obstacles, you don't want sort of things that would impact anyone. Fear about pain, lack of energy, medical complications, lack of financial resources, feeling too old to learn something, which is feeling too old to learn something new, which is I mentioned before, being alone, particularly if housebound, lack of transportation if these activities are being offered somewhere else, and sometimes perceptions of safety. And in older adults, they often have memories of areas, and they think of a neighborhood. I think, in my day, that neighborhood was dangerous, so I'm not going in there. Or in my day, that neighborhood was safe. And there's the reality of safety, and there's also the perceptions of safety working through. Okay, so next slide. And then you'd have to be aware of some of the benefits. If you're going to explain to somebody who's a bit reluctant about doing physical activity, or talk to them about talking to you about physical activity, you need to be prepared to say what some of the benefits are. So it could be about reducing the risk of developing heart disease, diabetes, high blood pressure. It could improve mood, help with weight control. So all of these are examples of benefits. Okay, so next slide. Okay, so all right, so here we go. So you all have had chats with members of your mosque community. A researcher may want to ask you to interview members of your communities, or you may want to have a chat about healthy behavior, which isn't an easy thing to do. It's not easy to sort of move. You're sitting down, you're having a nice conversation, and then you say, well, how often do you exercise? Is probably not the way to go about things. So you have to think carefully about, because people can take offence at that, because you say, are you saying I'm fat? So you have to be very careful. Or I need exercise. You do have to be quite careful about talking about health behaviours. So, but obviously chatting is actually a nice way of finding out informally what's going on in an environment. So if you were going to do an interview, you would need to ask things like, is it okay? So here's this diagram. It basically shows how you go from semi-structured to very structured. So conversational is not really on this diagram. It's just outside the diagram. Conversation is over here. This is if you were thinking about an interview. You'd want to do either a semi-structured one or a closed structured interview. So semi-structured interview questions would be, nice ones, open ones, like how has what you eat and drink changed as you've gotten older? It's a nice one because it's open questions, you know, which encourage people to share. Harder to document, of course, because everyone gives different answers. Structured ones is very much sort of yes, no type of answers or selections. Okay, so and the purpose of interviews, as you'll know, for any of you who've been home care aides or community health workers or case studies, is to document your conversations in order to work out how to help people to change. So there's change talk, and then also how to assist them as well. Okay, so next slide. So what is an interview? So it's speaking in order to give information often. So it involves two people talking at the same time, talking together. And it's a situation where questions are asked and answers are given. And I know this probably seems very basic and very obvious, but I think it's a conversation with a purpose. So you're not just having a chat, you're having a conversation with a purpose. And in a research team, it will mean that you have been asked to elicit information, to inform something. So if we get the next slide. Okay, so here's the spectrum. So you've got conversations, free-flowing, no pre-agreed questions, two participation, speaking and listening. Got the semi-structured, please tell me about. What do you mean by that? Follow-up prompts, could you say more? And then the really structured, so questions like, do you like? And everybody follows the same script so that the researchers can actually then compare all of the different answers because everybody's following the same script. Okay, so if we go to the next one. Okay, so I have questions for you all. So just to make sure, so deep breath. And which one here? So I should actually say the interview, right? Is the green person or the blue person the interviewer? So if let's say the green person is A, the blue person is B. Do you think the green person is the interviewer or the blue person, or both? So if you could pop your answers into the... Okay. Okay, that's interesting. All right, okay. So I hope you weren't led by the header on that one. Okay, so you're thinking the interviewer is the listener. Very good, very good. But who's asking the questions? So, it is true, and I'm glad you all said that. I'm glad you all said the interviewer is the listener. So I've obviously got a group of listeners, which is really nice. I'm very pleased that I've got a group of listeners. Okay. Unfortunately, researchers tend to ask the questions. Okay. So I think the answer here is both. I would say that it's both. You have to be able to ask a question and you have to be able to listen to the answer. All right. Okay, guys. So let's go to the next slide. So the skills you need are absolutely active listening. And I do think that's one of the problems we've got with Zoom is I can't see you all, you see. And active listening involves looking at your body language, noticing whether, all of those sorts of things. If you're nodding, if you're sort of not, if you're looking a bit puzzled, those are all really valuable active listening skills because people's bodies, they speak very loudly, the way people sit, the way they sort of, they talk a lot. So active listening, and it sounds like you actually all have good experience of that. I really like the fact you all did blue. That's really good. Okay, ability to answer open-ended questions and follow up. That should be ability to ask open-ended questions and follow up. So, can you actually ask somebody an open-ended question? Like, I've forgotten can we go back to the back? I've forgotten what the open question was. I had another one. Yeah, so that's right. So that one. So ask, not this one, not that one, the next one, Fatima. Oh, no, I think, can we go forward? Sorry. Yeah, so an open-ended question would be, next one. Sorry. So an open-ended question would be, what do you please tell me about. That's an open-ended question, because you're not saying, do you like tea or coffee? You're saying, please tell me about, and then you could follow up with, what do you mean by that? So, but please tell me about is inviting the person to share an experience. It's not telling them what to give you, the answers to give you. All right, so if you keep going. So you have to be good at asking questions as well as listening. So being responsive to the words that the person you're asking the questions is using. So you remember the thing about creaky joints and arthritis? Somebody talks about their creaky joints, you in your mind you're thinking that they're telling me about arthritis. Be responsive to body language. And constructive listening is deep listening, can be part of creating an equitable environment. I went on a really, really good course. It was about racial equity and in research. And I nod a lot. And what they pointed out is that actually by nodding, I'm sort of conveying to the other person that I want them. You could almost say, you almost have to not give your face away in some ways to get real answers, because by nodding I'm being encouraging, yes, but I'm also not really a labeling person to tell me something that they don't like about a system, or that that they find, or even that they don't like the fact I'm asking the questions. So it's a difficult one, because older adults in particular, this is one reason I like working with older adults like you to nod. They like you to engage with them through the body language. So it's all, but you have to be very careful about the questions that your body language when you're asking questions. Okay, so the next slide. So asking questions, yes. So here we go. So an open question requires that the person thinks and reflects before answering. It requires a longer answer, and you handing the control of the conversation a little bit more to the other person. With a closed question, you can often just answer it with a single word or a short phrase. They're quite easy, quick to answer, and they often give you facts. And that's what we've been doing when we've been asking you questions, following, for knowledge checks. We've been giving you closed questions. We sometimes are giving you an open one, but most of the time we're asking you closed questions. Okay, so next one. So here's an example. So yeah, closed question. Do you drink coffee in the morning? Your respondee will just say yes or no. But if you say, what do you like to drink in the morning? Your respondee may say, I like to buy a cup of tea on my way to work. They might share a little bit more information. And from a qualitative researcher's point of view, just to throw another word in, you don't really need to know what qualitative research, you don't need to remember that phrase, but it's about experience. It's about the lived experience, about finding out about the lived experience. And questions, and asking people questions, is a very good way of doing that. But you can't just ask them random questions. They have to be about a particular topic. So that, yeah, okay, next. And often open questions are better. So let's just pause. And I should have put that. Okay, let's do this one. So is this a closed or open question? So if you can answer in the chat to it's great weather today, isn't it? Is that a closed or an open question? Yeah, absolutely. And what are your plans for today? Is that a closed or an open question? Cool. Well done. So it's an open question, yeah. Is now a good time to talk? Is that a closed or an open question?
Depends who you ask.
Yeah, I know. And sometimes, yes, yeah. That is true. But generally, you'll get a yes or a no, won't you? No, yeah, maybe. That's right. I know. Yeah, that's a closed question. What fruits and vegetables do you like? Is that a closed or an open question? Mm-hmm. Cool. You got this down to a T. Very good. Excellent, guys. Open. And how old are you? Yeah, that's right. Yes. Yes. Yes, you are right. I will have to say, as a gerontologist, I never get a one-word answer on that one. So people will not tell you that they are 75. They will say that they are 75. They are, 75, but age doesn't matter. There's always a little bit more on that one. So yes, but you're right. It is actually a closed question. So if you have the next slide. Okay, so here we go. So here's an example of a health script behavior, and this is about the physical activity. Okay, so I like open questions. So I think on this, surveys are closed questions. Surveys are often closed questions. But if you're doing conversations, good conversations can often be helped by these types of, this is a semi-structured sort of conversation in many ways. So you could say, do you mind if we talk about you? What do you feel about physical activity? Asking people how they feel about things is much easier than what they think about things. How do you feel about it? It's about them. It's about their everyday experience, about their lived experience. So how do you feel about physical activity, or what do you feel about physical activity? Another example of an open question is that you show that you understand. You're not judging. This is the problem, particularly with health and particularly with eating. So keeping up with physical activity can be a tough business. Even with the best intentions, it can be difficult to find the right time to exercise. When you don't feel like being active, how do you get back on the straight and narrow? So again, you're asking them, you're not saying you don't do enough physical exercise and you must change your ways now. You're saying, let me explore with you how best to do your exercise. And as we know, because we've got those general barriers, we know that sometimes it's it could be medication, it could be what the time they take the medication, it could be the fact they can't leave the house, they can't go out on their own, they need a and then of course they may lapse, and it may be winter and they can't get out of the house for a whole week. So, and you don't feel like going out anyway, you just feel like staying inside. So how do you then get back on the straight and narrow? So you could find out and they will all, because they've got 85, with older adults, because they've got 85 years of experience, they will know how to get back onto the 80. You just need to sort of get it out of them in terms of how they deal with it. So would you be interested in learning any of these activities is then a way of saying, right, our mosque is thinking of doing X, Y, and Z. Would you be interested in learning about any of these, or taking part in a Zoom sort of exercise, bending and lifting, sitting, bending and lifting exercise sort of session? And then the good thing always to do is just to show that you've been listening. So summarize at the end, summarize in the close. I just want to make sure that you've had the chance to express your preferences in your own words. Is there anything you'd like to tell me about your physical activity and mobility? Anything else you'd like to tell me about any specific that you'd like to tell me about your physical activity, mobility, or the type of access to that would help you? And now we talked earlier a little bit about, Fatima mentioned that amazing program where mosques were making, they were coming up with more accessibility for disabled members of mosques. So they might say, well, actually, I'm in a wheelchair, and so I need to be able to go to a mosque where I've got access. Or they may say, I can't leave the house. I really can't leave the house. Now, Bishop Gordon and the team down in Tridestone, the Baptist team, they got this church choir to go and sing in the streets outside a whole series of older adults who couldn't actually get to church. And so sometimes there are things, or drive-by prayers, those sorts of things. Some things, I mean, which aren't necessarily directly to do with physical activity and mobility, but just as Fatima started with a wonderful piece from the Quran, there are pieces from I'm sure that I know that there are pieces. I've heard the Baptists talk about pieces from the Bible about activity, and I'm sure the Quran has some good advice about physical activity as well. So okay, if people can't do them, but they can hear about them, in different ways. So be creative. So the next step, eliciting change. Given what we've talked about, how can I assist you to do these things? How can I assist you to watch out for your exercises and your behavior and stop you falling off the cliff with them? Okay, so next slide. Okay, and then try adding your own style as well, because obviously just repeating questions can be a bit repetitive. But so rephrase the question so that you understand what you're asking, help people to get their head around the topic. How do you feel about? Translate, repeat what the other person says using their own words. And you could also say, oh, so I understand. So if I understand rightly, it's important to you too. And then just saying affirmation, okay, that shows strength of will, is just affirming what they're doing is often, or their determination to change, which is often sort of there too. Okay, so the next slide. If you've ever learned motivational interviewing, this is a little bit. This is a sort of a simpler version of that as an approach. So just at this point, is this helpful to you? Do you think that MOS community members would understand this language? So could you use this type? Could you actually? Do you feel how confident? Do you think you could ask questions about healthy behaviours at this point? Could you imagine having a conversation like this? Okay, so let's answer that question. Could you imagine having a conversation like the one that we've just talked through in order to find out about people's physical activities and behaviours? So if you could just say yes or no in the chat, that would be great. It's absolutely okay to say no. Thank you for saying that. It's very nice that you said yes. That's awesome. But it is all right to say no, and let Fatima know if you know this isn't something you're feeling you can engage with. But that's great, and I think that's awesome, because you could become a good part of a research team if you feel confident, because this is the type of structured conversation a researcher would be probably asking you to have, right? Now, what extra steps do you think you would need to take if you wanted to ask people more personal questions and collect more personal data? Okay, does anyone want to sort of just yes. So if I can, so have a think about that. Just have a think about that. More involvement, yeah. Okay, lovely. Yes, yes. Those are. Thank you. Yes. Yes, those are all great responses. So more involvement, I think that is right. That's where trust and transparency comes from. If they can see you and they know you and they see you at work in the community, much more likely to talk. They'll say, oh, that's the lady who comes and talks to us about a physical activity, or yeah, just seeing you, understanding it. But also, actually, it really does matter that I think that you are fellow members of the MOS community. Yes. Have someone close to them introduce you is also important. Yes, and particularly with older adults, sort of, caregivers involved. The thing with caregivers is they will often ask you as a researcher, what are you doing? What are you asking my mother? Or what are you doing? So keeping the caregiver sort of informed about what's going on is important. I think also having a forum where people can send in questions privately is genius, is a good idea too, because just as I said, I nod a lot. So, but that doesn't encourage somebody to sort of necessarily share something embarrassing or something, not embarrassing, but something they're a little ashamed of. I'll give you an example from food and diet industries. I've interviewed a lot of older people who they grew up, sort of when Coca-Cola came out, and it was Coca-Cola, like it was a bit like smoking. It was a cool thing to do, and you drank Coca-Cola and you drank a lot of it. And so a lot of older adults find it difficult to give up drinking Coca-Cola, but they also know they shouldn't be drinking Coca-Cola. So they're very reluctant to tell you that there are 3 bottles of Coke in the fridge. But what they might do is they might tell their home care aide that there are 3 bottles of cola in the fridge, and because the home care aide knows them much better than the researcher. So in that situation, yes, it does help a lot to have somebody close introduce, and have that person as being a bridge. And I think so many, you, in the way that you've been sharing things, you are bridges for, you understand the family situation, the cultural complexity of being often being an immigrant, being a mosque community member. These are shared experiences, and that's from the shared experiences is a basis of trust. What I would also say, and yes, as you say, some people may not speak English well, and so you would need to have aid in other languages availability. And as Andy said, they make the doulas, the Chicago voluntary doulas. It's important to have people who can speak different languages, and that's part of trust as well, or to make the offer that it's there, So now, what I did want to also say, if you're going to ask more personal questions, this is where, if you're approached by a clinical researcher, there's an extra layer of an ask to involve people in the clinical research, which might involve taking swabs or blood, or that's a different world, and I don't want to go there just yet. We will come back to that, but that's also as you can see, a researcher can't just go into the mosque community and start sort of taking samples. So there are all those issues to take on board as well. Okay, so the next slide. Sorry, I know we're just coming to the end, I think. Okay, sorry, Fatima. So this is where we're sort of yes. So the difference between this is where Fatima and I wanted to sort of talk about the difference between CBPR and PCORI, precisely because of the issue I've just sort of highlighted, which is that sometimes you might be asked to help researchers to engage people that in clinical research. Okay, so over to you.
Okay, thank you so much, Dr. Johnson. There was a lot to think about what you have put together today, and I think it is very important for all of us to gauge ourselves, or to focus now in terms of moving our attention to the person who we would be talking, and listening and gathering information and moving into the data collection activities. So I just want to highlight just a brief thing that these opportunities for data gathering is always on. There's no turn on and off button for these. The community need is a persistent thing, and that's what we are trying to see, that where are in the community the need is higher, that requires help, and where it really doesn't need any help. And that's really the approach of CBPR, that you have this continuous need that's present, and it's guided by these questions and data collection methods. So CBPR is really is an approach. It's about having all of these things working in the background as you are practicing patient engagement. PCOR, on the other hand, is really it's an institute with a methodology, and I think a methodology means that it comes with its own Bible. It comes with the standards, it comes with the regulation and guidelines. So there are about 65 standards in the methodology, in this particular methodology. So whenever you would hear the word methodology, always connect that with a standards manual. So you have a project management methodology, you have the research methodology, and there are qualitative and quantitative methods, and there are standards that go with it. There's also there are many different kinds of methodologies when you go especially into the sciences. So I just wanted to make sure that people understand that the differences between CBPR as an approach of asking questions, probing, and getting the needs in there. There is no set methodology for CBPR. CBPR can go on with any of the clinical methodologies, whether it's qualitative or quantitative methods. You can deploy that in the community-based settings. And there is no set funder for the CBPRE. There are many organizations that are actually funding the community-based participatory research, and then there are focused community outcomes. That's what it is. With PCOR, you actually have PCORI as a funding body. It has its own priorities. It has specific objectives, and it focuses on patient outcomes, not community outcomes. So there is a one thing that's common to both of them. It's the logic model that becomes the commonality between, which is, and the logic model itself is a set way of conducting research, and that's where it ensures that you are changing the behavior of the subjects that you have, whether it's a community or a patient. So that's where the differences are. And I wanted to mention, okay, so basically the process of CBPR has 7 stages, and we will probably revisit this when we go over the PCOR a little bit more in detail. But one of the things I want to highlight is that CBPR can happen on a constant basis versus a research project that has a specific start and a specific end date. And with the community-based participatory research, it's more of a program, whereas PCOR project is actually a project with a start and an end date, but a program may go on, and a program can have many different projects within itself. So, for example, an enrollment program that we run every year, it's a different project. We're embarking on the OE8 project, which just starts November 1st and will go on till the September 30th of next year. But now we are in the OE7 project, which will end on September 30th. And so, or October 31st, 12 months. And right, one project ends, the next one begins. But that continuity of having the specific community outcomes makes it a program. Okay. Basically 7 stages. I'm going to revisit these slides later on when we talk about the community activities and planned work with. So I'm going to leave because Dr. Rebecca has focused you and oriented you to that moment of contact with the patient. I want you to leave with that sentiment here. Keep thinking about it. And I think what you probably want to have is, oops, I'm sorry, this is painful. I had some of these slides have animations in there. I want you guys to keep thinking about this particular slide and come up with your own bio sketch, something in this particular manner, because I really like this approach, having a picture and then personal pastimes, or what exactly does she like to do, and having some pictures in there, so it's a reminder. People relate other people with an image in mind. So I think this is great, and we can have once we document this project, and when we document every one of the CHW cohort here, we would like to see something very similar. And I know you guys have your profile pictures. You may want to have an action photograph of yours, which is great. So this would be really nice to actually work on. So Monday we are going, after this, you will probably receive you will receive a Google form questionnaire, about 3 to 5 questions, asking you to evaluate the first part of this coursework, which was the orientation to community health research. Now, Monday onwards, for about another week, we would go into the the PCOR methodology. So that week we would strictly work with PCOR methodology and how does PCOR methodology engages community for asset mapping. That's what we would work with. And the third week, actually that coursework will end on the Tuesday. So next 10 days we would have it. And then after that, it's basically getting everything together and into practice. So the first part was the orientation to community health research, and that's what ends today. And then we're going to move into that PCOR and how that connects with. So you're going to receive a little evaluation form this afternoon or this evening. So, but make sure that you finish it up by tomorrow. It's a just basically your opinions on how this program or how the first part went and what were the some feedback from you guys. So that would be nice if you could kindly let us know so we can adjust our next session accordingly. And then basically, let me go here. Okay, so any other questions that we can take at this point? Okay, I know we had some questions in the chat box, I guess. Oh, Dr. Johnson, there's okay. Any other questions that we have? Jimmy asked. Jimmy has some questions for Dr. Rebecca. You're probably reading this through. Any other questions that you have and you can talk about on the so that everybody could hear and listen to? Any other question, guys? Okay. So also, I would like to know whoever would like to volunteer for their experience and share their experience on Tuesday, Wednesday, and then Thursday. There is another session with Dr. Patela's. His sessions are pretty heavy in content, so we were not. Communication takes some time, so virtually it's not possible to have both in the same session, but we would like to have each one of you volunteer one of the days for the for your sharing your experience, and all the way till Wednesday. So we have about 3 more days, or maybe perhaps 6 more sessions. So if you guys don't have any further questions, then hopefully we will, inshallah, we will see you on Monday.
Yeah, thank you ever so much, everybody. I really appreciate
it. So much, Rebecca. Thank you. It was tuning in to the actual patient today. Thank you.
Yes, thank you. Thank you all.